Hello, girls and boys. We are doing macroscopic urine flow histology. The functions are storage of urine, excretion or micturition of urine at a convenient time. And a reminder, from minor calyx on, there is urine does not change anymore. No more exchange with the blood. Okay, this is a little bit of review for you. Because, in OSPI, you can always anticipate electron microscopic image. So the first one shows you the principal cells. You can see that they are very empty, not much organized, only 1 or 2 mitochondria here and there. And the green arrow shows you molecules are moving from urine to blood. So therefore, this is what principal cells are famous for, the sodium and water reabsorption. Now the second image shows you very little remnant of microvilli. Here's the nucleus. Here is a cuboid epithelial cell with lots of mitochondria. And the arrow is showing you molecules are moving from the blood of the peritubular capillary into the lumen of the tubule. So this is basically the picture of secretion in the distal convoluted tubule. The number 3 is a three-dimensional electron microscopic blood vessel image in the cortex labyrinth. And this is where filtration will occur, where you can see the glomerular capillaries. The image number 4 is an electron microscopic image of 2 transitional epithelial cells sitting next to each other. This would be the nucleus right in here. And my main purpose was to show you the tight junctions between the 2 cells so that the urine cannot flow between into the tissues, into the lamina propria. So this is the picture of strong epithelium for urine storage, but it also stops urine leakage between the tissues. Okay, image number 5 is going to show you a flat nucleus of a simple squamous. Is probably more than 1, maybe 2 simple squamous epithelium, but the knife missed the other nucleus, which, if it's urine inside, then this is a thin loop of Henle. And image number 6 is very important that you recognize the heavy microvilli. Here is the round nucleus of a cuboid epithelial cell, lots of mitochondria. So this is a cell from the proximal tubule. The green arrow shows you the molecules are moving from the urine toward the blood. So therefore, whatever the proximal tubule is doing, most of the time, this is reabsorption. So I also wanted to show you that, I hope you remember that histologically, the loop of Henle, the thin loop of Henle, where the counter current multiplying occurs, histologically is identical with any kind of capillary. Now, I chose for you the vasorectal capillary because this is where they're gonna face each other, and this is where this simple squamous epithelial cell that we call endothelium. Remember, we don't call it endothelium in the urinary system, only in the cardiovascular system. These 2 guys are gonna do actually exchange with each other, what we call counter-current exchange. Why is it counter-current? Because the flow is the opposite. Now, one of the very good multiple choice questions are asking, of course, about the different kind of epitheliums. And usually two simple epithelium is looking at each other, you know, one on the blood side, one on the urine side, as they're gonna exchange with each other. So let's look at the different examples. Okay, so this is maybe the most important thing, that every image you recognize the simple squamous epithelium, black line basement membrane, or you recognize the simple cuboid epithelium with microvilli and lots of mitochondria. Again, endothelium. Now this is simple cuboid epithelium, no microvilli or maybe remnant, less mitochondria. And here again, endothelium, simple squamous epithelium. And look, you're gonna have a lighter cell and a darker cell. So that gives you a clue that this is gonna be the cortical collecting duct. Okay, so now here is the big questions for you guys, right? And the answers are written on the next page. Is, went too far. So the ADH water reabsorption is going to be here. We already did this in the other lecture. The black line is where the ADH arrives from the bloodstream, binds to its receptor on the principal cell. Principal cell wakes up and start making aquaporins. And this green arrow shows you the water reabsorption from the cortical collecting duct into the peritubular capillary. Okay, reabsorption from proximal convoluted tubule to peritubular capillary. It's gonna be this guy, because we already identified the simple cuboid epithelium with microvilli, lots of mitochondria, and green arrow shows moving from urine to blood. And finally, this is showing you a secretion from blood to urine in the distal convoluted tubule, where are no microvilli and less mitochondria in a simple cuboid epithelium. And you see, you can see very nicely, this is proximal, this is distal, and this is cortical collecting duct, because it has two types of cuboid epithelial cells. Now, this is summarizing for you what simple epithelium are facing each other. Now, technically, anytime we talk about blood vessel, capillary, arterioles, any kind of blood vessel is always simple squamous endothelium. So we are done with that. And then, so if simple squamous endothelium and simple cuboid epithelium with microvilli are looking at each other, simple squamous, simple cuboid with microvilli, lots of mitochondria, then you know that we are doing an exchange at the proximal convoluted tubule in the cortex. The same thing here. If the endothelium is facing a simple cuboid epithelium with no microvilli, less mitochondria, then you know that we are looking at an exchange at the distal tubule. Now, this one is I put here for you so you can compare these two guys with each other, because it's technically the same thing. This is simple columnar epithelium with a little bit of microvilli, very little mitochondria, like empty cytoplasma. So you are looking at basically the principal cells in the papillary collecting duct of Bellini in the inner medulla. And again, this is ADH just arrived. We woke up the principal cell, and this is water reabsorption. Just like what we did in the cortex before is happening also in the medulla. But the epithelium is changing. As I told you, the epithelium is rising from the cortex through the medulla all the way until the papilla. Okay, so the next image is showing you one simple squamous and another simple squamous are looking at each other. So this kind of situation cannot be anything else other than if there are red blood cells, this is a capillary in the vasa recta. If there is urine here, this is the thin loop of Henle. And there is the exchange. Okay, and yes, I put here for you, if water can go across but sodium is blocked, that's technically the descending thin loop of Henle. If the opposite happens, that again, simple squamous, blood inside, capillary in the vasa recta, urine inside, thin loop of Henle. Now, if sodium can go across, but water is blocked, basically there are no aquaporins, then you know that you are in the ascending thin loop of Henle. And this is a little note for you that this is the one and only place in the body where water does not follow salt or sodium. This is key to making different concentration of urine. And again, I wanted to show you what counter current really means. It means if the urine is going down, the blood is going up. If the blood is going down, the urine is going up. This is what's called counter current. And this is a repeat of the ADH water reabsorption in the papillary duct of Bellini. The next image now just summarizes for you the epitheliums. And technically, simple squamous endothelium, simple squamous epithelium that you don't call endothelium in the loop of Henle. Same thing on this side. And here again, endothelium looking at each other with a simple columnar epithelium with short microvilli, empty cytoplasma called principal cells. So you know where you are. Okay, so on the last image, I summarized for you guys the 3 hormones that are made in the kidney cortex. And probably the best would be just we're looking at the last image where it totally explains to you that this is the simple squamous epithelium or endothelium, blood inside. So this is a capillary. And this endothelial cell is secreting erythropoietin hormone, protein hormone, into the blood of the peritubular capillary. And you remember this hormone is going to wake up the bone marrow to make more erythrocytes. Now, this one is the my drawings of the juxtaglomerular cells right in here that are modified smooth muscle cells in the tunica media of the afferent arteriole. And the moment I say arteriole, remember we have 3 layers: tunica intima, media, and tunica adventitia or externa. You see, capillary has only tunica intima. And the black line again, guys, is the basement membrane that all epithelium should have. Few exceptions. So this is your arteriole, mainly afferent arteriole. The green is basically the green collagen fibers in the, and of course there are here's the boom, boom, boom again, fibroblast collagen ground substance. But basically, this is your adventitia or tunica externa. And now the JG cells or granular cells are secreting renin, protein hormone, which is also an enzyme, into the blood of the afferent arteriole, and is going to wake up the renin, angiotensin, aldosterone system to fix the arterial blood pressure so we can have a normal filtration in the glomerular capillary, which is the first step, urine formation. If the first step is messed up, there's no urine, which is not a good thing. We can call this kidney failure. And finally, again, this is the simple squamous epithelium or endothelium with blood. So, and This is a simple cuboid epithelium with microvilli, lots of mitochondria. So it looks like this is the proximal convoluted tubule looking at the peritubular capillary. This is where vitamin D activation occurs and then secreted into the blood of the peritubular capillary. So I hope that you understand what I was trying to teach you, that the two epitheliums that are facing each other from urine to blood or blood to urine. These are the objectives, and now we're gonna turn our attention on the actual macroscopic tubes. And you already know this from minor calyx, major calyx, renal pelvis, ureter, urinary vesicle, urethra. And here's the see the world. Officially, these two guys are the lower urinary tract, and we are dealing with macroscopic, so 3 layers are making up the wall, and the main function is urine storage and urine outflow. And remember, too thick, so no more urine formation. Now, the next image is what I wanted to show you very nicely. The microscopic urinary tubules in the nephron. And here on the right side is a macroscopic urinary tube. It's technically the ureter here. Structurally, look, I think it's beautifully, you can see. Only a very thin one layer or simple epithelium everywhere. That's it. And yes, there is a basement membrane that you cannot see. So therefore, urine formation possible. Right now, I can't put my finger on a capillary bed, especially when it's so orange and pink. That's why I like to use the purple kidney for capillary beds. But it's there. You remember capillaries are kissy, kissy, huggy, huggy, the urinary tubules, so they can have exchange. The first tubule, you remember, is the pars convoluta of the proximal tubule, and the last is the papillary collecting duct of Bellini. Okay, the macroscopic urine tubule is now thick, and it's going to have 3 layers. It's going to have and the epithelium becomes stratified. You remember it was all simple here, stratified epithelium. So it's already too thick to make urine. Then the mucosa is, the pink is the transitional epithelium. This sharp red is the lamina propria connective tissue. Together is the mucosa. Then this light pinky is the muscularis, smooth muscle layer. And of course, the adventitia. And as I said, too thick for making urine. The first one of this structure is the minor calyx. The last is the urethra. Okay, so this is, again, summarizes for you now the female urinary system and the male urinary system. Basically, the two is identical. Whatever you see in front of you, up till this red line, left and right, everything is transitional epithelium. And you remember then the 3 layers that we just covered. There's only one exception, the urethra in the male penis. That's not on the image. Okay? And also I wanted to make sure that you understand that the red line is your bum, where you are sitting. Beautiful name is anatomically the urogenital diaphragm. You can also call it the pelvic floor. But this is where you are sitting on both sides. So you can see that the two systems until the end of the female urethra and until the end of the prostatic urethra. Again, this is the prostate gland, and this is the urethra inside. So up till this point, the two things are identical. It starts at the minor calyx in both, and the last part of the where you see the transitional is the female urethra. In male is the prostatic urethra. Okay, let's talk about transitional epithelium for a minute. It has a structural name, stratified cuboid epithelium. On the top, the cells look like dome shape. Functionally, it's transitional. What does that mean? That it is capable to adjust to low and high urine volumes. It can accommodate the fluctuation of the volume of the urine. Location name, urothelium, which means the epithelium of the urinary system. Just one word here that, as I told you before, it starts in the minor calyx, and usually it's thinner, only 2 layers of epithelial cells, and as you are moving forward, as the urine is flowing, it's getting thicker in the ureter and in the urinary vesicle. Okay, so how is this fluctuation can occur? 2 ways: by decreasing and decreasing the number of the layers in the transitional epithelium, or by increasing and decreasing the surface plasma membrane, because the surface plasma membrane can actually invaginate into the cytoplasma, hiding. One clinical note: cigarette smoking causes high concentration of carcinogens in the urine, and it can lead leading cause of urinary cyst cancer. Okay, so this image just summarizes the same thing. This is the low urine volume, 6 layers of epithelial cells in the transitional epithelium, and the surface looks like dome-shaped cells. Why? Because you have low urine, so the transitional epithelium is not stretched. Now let's look at the high urine volume. Here, the epithelium is stretched by the urine volume. So it stretches out to 3 layers, and the surface is gonna look flat, squamous, transitional epithelial cells. Okay, now this is gonna show you, on the left side is the light microscopic image of transitional epithelium, and you can see very nicely the dome shape. And on the right side, you're gonna see a chunk. Okay, I'm showing you here, not the whole entire cell, just a chunk of one dome-shaped surface epithelial cell on electron microscopy. And you see, light microscope, it looks so smooth. In electron microscope, it's not smooth. Why? Because as I told you, the surface epithelium can actually invaginate into the deep and hiding inside during when the urine volume is low. And the plasma membrane looks like these little white balloons inside. You can see it here, here, and here. Okay, now this image is electron microscopy now of 2 transitional epithelial cells. So this would be cell 1, like this. It's hard to see where it ends, but this is cell 2. But the point is that there gotta be a tight junction at the lumen where the urine is, because this organ is designed to be impermeable so that the urine cannot leak out from the lumen between the epithelial cells into the lamina propria and then further down into the muscle layer. And there is here's another magnified tight junction. So what is happening here? Storage and stoppage of leakage, causing impermeability. Okay, now we're gonna start from the top to bottom, but we actually analyzed everything. Is really repeat. Minor calyx is the first where the transitional epithelium shows up, and the first smooth muscle layer shows up. And of course, major calyx renal pelvis follows. And this is utterly explained to you. This is the area cribrosa labeled with number 1. So this territory facing number 5, which is the lumen of the minor calyx. And on the other side, the transitional epithelium shows up, as I just said, first time. Okay, so let's look at the next image where it's more, zoomed in. So again, this is your area cribrosa. These are the lumens of the papillary collecting duct of Bellini. And the green arrow shows you how the urine is coming through. You remember in the lecture, I told you that this looks like a shower head. And the tube is lined with simple columnar epithelium with short microvilli, which is this pink line. And these guys have a name. You remember? These are called principal cells. And what's this sharp pink is in the middle? This is the interstitium, guys. This is where there is connective tissue holding the thin loop of Henle. And of course, the vasa recta is also right there. So therefore, this territory is where the place of the sodium gradient is created by the thin loop of Henle that we call countercurrent multiplier. So that is sitting right in here, guys. Okay? So number 5 is the lumen of the minor calyx. On the other side of the cliff, right? This is now your transitional epithelium. You can see very nicely the dome-shaped cells. And here, number 7 is, you can see the fibroblasts in the lamina propria connective tissue. Then this is the first smooth muscle in cross-section that showed up. And then here is basically the adventitia of the minor calyx. That is a kind of mergy with the connective tissue in the hilum. You can see it a little bit better if you go back. Okay, but either way, this is your 3-layer. Epithelium, lamina propria, which is mucosa together, muscle layer, and adventitia. Okay, so let's move to the ureters and in a transverse section. So this is showing you a relaxed ureter in cross section, and the mucosa, look, the lumen is star-shaped and the mucosa is heavily folded. Why? Because the urine volume is low. If the urine increasing, this star shape will go away. Very similar situation to esophagus. Okay, and again, here is your 3 layers. The mucosa is, the pink is the transitional epithelium, the sharp red is the lamina propria, together is the mucosa. Then comes the muscular layer, and this is probably the one new thing that I didn't say it so far, is the opposite of the GI. If you are in the proximal 2/3 of the ureter, then there are only 2 layers. And again, opposite of GI, inner longitudinal, outer circular. I recommend you just remember LC. When you are getting closer and closer to the urinary vesicle and cyst, it's going to start looking like urinary vesicle or cyst. So 3-layer will show up, and outermost longitudinal. So I recommend for you to remember LCL, inner longitudinal, outer circular, and the newer layer, outermost longitudinal. And since this tube is retroperitoneal, there are going to be some adipose tissue, retroperitoneal adipose tissue. You can see neurovascular bundles. And anteriorly, if let's say this is the anterior view, And if you zoom in, you should be able to see mesothelium of the peritoneum. And what is the major function? Peristalsis of urine as a bolus from kidney to the urinary vesicle or cyst. And I would like to ask you guys that please write it down clearly what the ureter is doing, if that is the question. Okay, let's talk about kidney stone. It goes with a horrible colic pain as the muscular layer is contracting. And no bleeding will occur as long as the stone doesn't cut through. But anyway, the next image is showing you that. So anyway, here is the kidney stone. As long as it cuts through the avascular urothelium, there's no bleeding. If it's gonna cut through all the way to the capillaries of the lamina propria, bleeding occurs and the urine will be bloody. Here you're gonna read it later, the different kind of symptoms, but okay. Now let's move on to the urinary vesicle, and it again shows you almost it's basically the same thing what the distal ureter is. The new information is this infraperitoneal organ. So it means that the peritoneum goes on the top of the urinary vesicle. So therefore the mesothelium, here it is, superiorly, you're going to be able to see the mesothelium. And everywhere else where there is no serosa, you will see adventitial connective tissue. But here is the three layers again. The purple is the transitional epithelium. The sharp pink is the lamina propria. So the two together is the mucosa. And here comes the LCL. And the urinary vesicle, you call it detrusor smooth muscle. Okay? And here is either serosa or adventitia, depends on where you are. What is the function? Distensible reservoir or storage of urine, contraction during micturition, relax during urine storage. Okay, and you can see we just came from the minor calyx ureters, so we are here right now in the flow. This image explained to you the different features of the transitional epithelium or urothelium or stratified cuboid epithelium. You can see 5 to 6 layers of epithelial cells on top of each other. Often you're going to see binucleation. One is here, another one here, there is another one, and guess what? This is a mitosis. And during low urine volume, as we said before, the surface dome-shaped epithelial cells are bulging into the lumen. And I also labeled for you again. This is your transitional epithelium. The pink is the lamina propria. The two together is the mucosa. Okay, the trigone of the urinary vesicle. The point is that there are no rugae here. It's totally smooth. And the three corners, these are the two openings of the ureters, and there are no sphincter muscles there. And the third corner of the triangle is the sphincter of the urethra. So there is a little muscle sitting here. So how is the urine is not going to flow back from here to there? Because there is a little valve here. What is the function of this trigone? It is sensitive to stretch. You remember it cannot, there's no rugae, so it cannot open up and flatten out like ruga can do during high urine volume. So it's going to be really stretched, which is going to be a signal to the brain to time to look for al-hammam. Okay, this is just a terminology slide to remind you that One of the reasons it's really good for you to say urinary vesicle or cyst, because you're going to use it at the rectovesicular pouch in male, and you're going to use vesicouterine pouch in female. Okay? This is also called the Douglas pouch, named after a Scottish physician. And clinical terminology, cystitis, the name of the inflammation of the urinary cyst. Finally, guys, urethra. And what I'm showing you, that the two guys are almost identical. Yes, the male is longer, shorter. So the difference is, here it is, the big difference. In the male, there will be two kinds of stratified epithelium: transitional and stratified columnar. In the female, because it's so short, all you have is transitional epithelium. Everything else is the same. LC, connective tissue, normal serosa. And yes, the openings and the sphincter muscles are identical in male and female. So I wanted to show you that this is the rabbit penis slide we have. This pink in the middle is bone. Surprise, surprise, there is a piece of bone in the rabbit penis. But where is the urethra? I put it here for you in this zoom sign. This is the penile urethra. So the urethra in the penis. When you zoom in, that's where you're gonna see the stratified columnar epithelium. You can see the oval nuclei facing the lumen. 1, 2, 3, like about 5 layers of columnar epithelial cells on top of each other. And all around is the lamina propria connective tissue, purple collagen fibers. And the nuclei of the fibroblasts are gray. Okay, so we're gonna focus on the 3 parts of the male urethra. This is the prostatic urethra. This is where transitional epithelium for the last time. Then you remember, this is your bum or the urogenital diaphragm. This is what we're gonna call membranous urethra, labeled with 2. Okay, again, observe the urethra is the green guy. Okay, and this is where stratified columnar epithelium will show up, and it will continue in the penis. So the penile urethra is also stratified columnar epithelium. Okay, can kidney stone travel through here, guys? The answer is yes. It can travel through, all the way through, extremely painful, and yes, it's possible to deliver the kidney stone through the penis like a baby. And here is your histology slides, because that's what you're really going to be tested on: transitional in the prostatic urethra, stratified columnar in the membranous, and in the penile urethra. Okay. So this is showing you the openings. Guys, this is nothing new. All openings of the body looks like this, okay? Whenever you get closer to the openings, it starts becoming stratified, squamous, non-keratinized, what you see here. And once you exit, it becomes keratinized and it becomes skin. And again, same in male and female. This is what we call the external urethra orifice. Okay, let's talk about sphincters. Okay, so very important that you know, sphincter muscles never hang out all alone. They are always part of a muscle layer. So what does it mean? The internal urethral sphincter, which is your involuntary smooth muscle, you cannot control because it's controlled by the autonomic nervous system. It is really part of the detrusor smooth muscle of the urinary cyst. It's part of this detrusor muscle. Okay. How about the external urethral sphincter, which is basically your voluntary skeletal muscle that you can control by the somatic nervous system. Now that's going to be part of the skeletal muscles of your bum bum or the urogenital diaphragm. Clinical note, when you are doing potty training of your baby, you are basically teaching the baby to contract the external urethral sphincter voluntarily to override the involuntary smooth muscle that you are not in control of. Okay, clinical note, urinary tract infection or UTI is a word for infection that affects different parts of the urinary tract. If it's in the upper part, this is the big names you are looking for, pyelonephritis, which is basically the pelvic kidney inflamed. Urethritis, the ureter inflamed. If the lower urinary tract is inflamed, cystitis, urethritis. This is your urinary vesicle and this is the urethra. Okay, so these are your summary slides that you can practice a couple of questions about transitional cell carcinoma. Answer obviously is A. Wherever you see transitional epithelium, that's where it is coming from. The next one is, where is the colic pain is coming from of the kidney stone? Is it from the ureter smooth muscle or the detrusor muscle? Well, the answer is both, because you remember the stone can travel through the entire system. So wherever the stone is, if it's in the ureter, this muscle is contracting, causing colic pain. If it's in the urinary vesicle, then this guy is going to give the patient colic, horrible pain. And what layer will be bleeding? We cover this. Only if the stone hits the, let's see, it's here, the C or the D, meaning the capillaries in the lamina propria. Otherwise, no bleeding, because transitional epithelium, stratified columnar epithelium is avascular. The end.